It's my great pleasure to introduce Belinda Lennox as the BMPA Medal Lecture giver today. She's a consultant psychiatrist and head of department at Oxford. You've come up very early, because I've still got the introduction to go. She's a consultant psychiatrist and head of department at Oxford and works in the Early Intervention and Psychosis Service. She's a vice chair of the Psychopharmacology Committee of Royal College of Psychiatrists. She's a steering group member for the National Clinical Audit of Psychosis. She's an associate editor for Schizophrenia Bulletin. But for today, her involvement really that we're interested in is as a psychiatrist in the early psychosis service. So she's done lots of studies over the years, so the Extend study with personalised care, but in particular today, hopefully, that her involvement in the Synapse-2 and PIP-2 studies will be most relevant to our talks now, carrying on our theme for this afternoon. Thank you very much.
Thank you so much, Boyd, for a wonderful, well, particularly for this wonderful afternoon of psychosis, which of course is, the most important topic to be addressing. And I'm just delighted to be here. BNPA is a wonderful organisation, actually so important for the future of this field, as hopefully I'll highlight in the next 40 minutes or so. So yes, I am a psychiatrist. I have always been a psychiatrist. I am a schizophrenia researcher. And I suppose to declare my biases from the beginning, schizophrenia, in my mind, is a neuropsychiatric disorder of unknown etiology, and we really are failing in our sort of discovery science and advancing our understanding and improving treatments for that disorder. So what I'll talk about is a bit about current psychiatric practice, actually, which I think links together quite a few talks from this morning as well, about the sort of real psychological and social aspects of psychiatric care, which I think we can be really proud of, and something we really lead medicine, really, in our ability to treat the whole person. And I'll tell you a bit, although Adam is going to tell you more about it, the sort of uncontroversial bit, the sort of unarguable fact that these new disorders of autoimmune encephalitides have very prominent psychiatric aspects and psychiatric presentations. And then I'll go on to the controversial bit, which I'm particularly interested in, is actually what proportion of everybody else with a primary psychotic diagnosis with schizophrenia might also have an autoimmune etiology. And I'll also dwell a bit on why that's controversial. Why is one so accepted and the other not? And then finish off, hopefully, with a bit of what should we do? But I'm also very mindful that those two previous cases that were presented are actually foremost on my mind, and I'm left slightly traumatized by not knowing what the answer is, and really hoping that we collectively can help those individuals. Okay. So I work in an early intervention in psychosis service, which is an evidence-based community mental health team. And we really do look after the whole person. We take everybody with a first episode of psychosis. We don't make any kind of diagnosis other than the symptoms that they describe. So more than 2 weeks of any psychotic symptoms, you will be taken on to an intensive community-based service looking after you for up to 3 years. And we provide medication interventions. We provide family interventions, we provide psychological interventions, we provide psychosocial interventions. We get people housing, we get people benefits, we give structured family therapy, all of which have an evidence base for improving outcomes in people with psychosis. We have an assertive outreach approach because we know in psychiatry the people least likely to attend outpatient appointments are the most in need. So we go out and find people. We see people in their schools, in their homes, wherever they want to be seen. So we have really good outcomes as a result. After 3 years, about 3/4 of people with a first episode of psychosis, of which about 60% have an end diagnosis of schizophrenia, 75% of those will be discharged to primary care without the need for ongoing secondary mental health services, which is a really good outcome for people with psychosis. So, wonderful, but really, I would say we have lost the brain in the process. So psychiatry and mental health services separated out from general hospitals, I suppose, about 25 years ago, largely, and it was seen as a sort of a need to build up psychiatric services because it seemed that, in competition with the whizzy cardiology or neurology services that psychiatric services lost out when they were in competition with these other specialties. So it's thought that putting them into their own mental health trusts would somehow protect their services. But actually, I would say that we've lost the brain in that process. It's really difficult, and it's virtually impossible, when I see patients in the early intervention service to do any level of interventions or any level of investigations, rather. So I can't get an MRI. I can't even really get a blood test. Is quite challenging. Doing a neurological examination with a kit, I can probably manage in someone's front room. But it's just really technically difficult to examine people and investigate them properly. And even then, when they become more severely unwell, like the cases that we've heard about, and they're admitted to expensive inpatient units, they are completely disconnected usually from the general hospital. So even when psychiatrists are really concerned about somebody, it's really difficult to get a response unless you sort of ship someone across in an ambulance, essentially, to A&E. And even then, as we know, the sort of diagnostic overshadowing that occurs in real life often means that those patients are dismissed, not investigated properly, and are sent back. And you get really poor outcomes for people with psychosis, with all kinds of other comorbid disorders. So we get worse outcomes if you get cancer, you get worse outcomes if you have a stroke, you get worse outcomes if you have any other diagnosis alongside your psychiatric diagnosis. So it's a major loss, and it's a major problem. And I think it's a core part of it, I suppose, and what I've been thinking about as to why it's so difficult and why we're so separate. It's not just the physical infrastructure, but it's our professional structures as well. We diverge. We're like separate species from medical schools, really. We go off into the sort of the medical neurological world, or we go off into psychiatry training. And I suppose, I spend a lot of the time on the psychiatric side wondering why we haven't been able to respond to the new knowledge generated through the discovery of these antibodies, for instance, into psychiatric practice. And I think one of the core reasons is our sort of lack of academic kind of training, essentially. The proportion of psychiatrists that have PhDs or that would identify as an academic psychiatrist is really tiny. And outside of London, there are several medical schools that have lost departments of psychiatry entirely because there are no academics to staff them. By contrast, neurology always did have the tradition of being a strongly academic field. A third of consultants would say that they're academic consultants. So you can't see in the little red bar, it's too small. But I suppose it's not just one way. So the number of neurologists that would identify as specializing in functional neurological disorders is a tiny proportion of consultant neurologists, whereas, as we know, it's a hugely common presentation to neurology outpatient departments. So there's a sort of a mismatch. Neurologists would generally specialize by disorder. Psychiatrists just specialize by age bracket, and the number of neuropsychiatrists is minuscule. So we need to do something about training, I suppose, is my conclusion from that. We need to, for the next generation, we really need to get people to work together and do something differently and do something better. Okay, and the end result, as we've heard of, the theme of today, is we really do not meet the needs of these patients, rare or common, that have these intersectional problems. They have a neurological basis to their psychiatric presentation. This is the case of Susanna Cahalan, a very famous case that you may have heard of. So she was a New York Post journalist who had an episode of schizoaffective disorder. She believed that her flat was infested with bed bugs. She had a sort of paranoid conspiracy, delusional beliefs, and she was admitted to a psychiatric hospital. She stopped sleeping as well, so very sort of characteristic, sort of abrupt onset, severe psychotic illness. She got worse with antipsychotics. She had some seizures, and she became, quite frankly, catatonic. And it was only from actually having a brain biopsy by the brilliant neurologist Suhal Najjar. She was diagnosed with autoimmune encephalitis due to NMDA receptor antibodies, and she writes about it brilliantly. And I suppose what I take away also is the sort of the stigma that she experienced with having a psychiatric diagnosis that seemed to shift when she had a diagnosis of a brain injury or an autoimmune encephalitis, which I think is also something that I witness as well. Almost the sort of the apathy. If you have a severe mental illness, there's a sort of a nihilism really amongst many clinicians of, oh, well, that's very bad and I'm sorry about that. And but really, we've tried clozapine and we're not going to go any further. I mean, much as we'd like to, but there's almost a sort of a hopelessness about it. Whereas actually with this diagnosis, it really is a hopeful, positive diagnosis. And she wrote, over 10 years ago, how many more patients are there who could be pretty much cured with relatively simple interventions? So that's what's been driving me for the last 15 years or so. And many of you will know that this is the story of the breakthrough science discovery of these neuronal cell surface antibodies, pioneered really by the brilliant lady at the top there, Angela Vincent, who was the reason I got into this area and the reason I came to Oxford over 10 years ago now and discovered the first of these antibodies against the voltage-gated potassium channel complex. And many more described since then, and I'm sure many more sort of rare special cases in carefully characterized individuals. But I suppose that I didn't really want to go into detail of the nature of these disorders, but more the nature in which they were so rapidly taken up into practice. And I suppose this is really symptomatic of our different specialties. So I suppose this is a story of clinician scientists. This is a story of careful observation of the phenomenology of patients presenting and of people trialing new treatments. Patients being given plasma exchange and almost a sort of a trial by intervention to work out that therefore is an antibody causing the problem and mapping the change in clinical symptoms with the antibody titers. And the rapid adoption of this new science into clinical practice worldwide within months, if not a couple of years. I mean, really amazing. And it's absolutely unacceptable in any neuroscience center, really, I would say, if somebody presented with a characteristic clinical phenotype, that they would not be investigated and probably even started treatment before they got an antibody result back, because people say, I know what that is, and I know how to treat it. So why is it so different if you're on the psychiatry side of the fence? And I suppose this is what I really struggle with. So the reasons why it was a breakthrough discovery were because these antibodies were against neuronal cell surface targets. Antibodies have been associated with autoimmune encephalitis for many decades, with encephalitis for many decades. But these are against neuronal cell surface targets and were therefore pretty easily to treat without killing the neuron and treat the underlying syndrome. That really was the critical factor. And I just want to say about the method of testing, because it is important, is that the way that we test for these antibodies is a really specific assay. So we grow hex cells that overexpress the particular antigen that we're interested in, and then we look down a microscope and look for the binding of the patient sample onto those cells. So it's a really specific test. If you get a positive antibody binding, it really can't be an antibody against anything else other than that protein that's being expressed on the cell. And they're also very sensitive tests. Okay, so the characteristic clinical features of NMDA receptor antibody encephalitis, I'm sure, are well known to everybody here. And I just want to stress that this is seen as a neurological disorder. It was described by neurologists, by neuroimmunologists, but it has always been psychiatric, neuropsychiatric. The majority of patients present to psychiatry first. They present with psychiatric phenomena. They present with abrupt personality change, with psychosis, with stopping sleeping, all the rest of it, but it's firmly to psychiatrists. They do not go to a neurology outpatient clinic, and they do not go elsewhere. And it's later on, it's a sort of 2 or 3 weeks later, that the autonomic disturbance, that the frank catatonia, the loss of consciousness, the life-threatening aspects, that's when they typically will end up in an ITU and get the diagnosis, if not picked up before. But it's the gatekeepers for the diagnosis have always been neurologists. So a psychiatrist, however excellent that many of us are, we might suspect and we might look for red flag symptoms or suspicions, and then we would refer to neurology to make the diagnosis and to start the treatment. We don't have the tools and we don't have the training to be able to say, actually, I'm going to, request the urgent MRI, do the lumbar puncture, and start the treatment. And maybe we should. So I really like this study. This is a study, a prospective study of 113 patients admitted to psychiatric hospitals with psychosis, collated by James Scott and colleagues in Queensland, Australia. And it's a really nice study because it's really inclusive. They made strenuous efforts to include everybody, whether you're on the psychiatric intensive care unit and lacked capacity to consent to research, you were included in this study. They really included the vast majority of everybody with a psychotic diagnosis. So it's quite representative. And what they found was in 113 patients, they found 6 with an antibody. And this was their initial case summary of the sort of symptoms that people presented with, and the psychiatric, the ICD-10 diagnoses. So I draw your attention to the diagnoses, the 28-year-old lady at the top there, thought all to be due to the cannabis. Substance-induced psychosis, extremely common diagnosis. Most of them had very short durations of illness, so, a few days most of the time. And you might say there's red flags, certainly, in the clinical symptoms. So there's catatonia, loss of consciousness, seizures in a couple of cases, but not in all of them, and all being treated in a psychiatric unit. So the first 4 of the patients had NMDA receptor antibodies. 1 had an antibody against the voltage-gated potassium channel complex, and 1 had an unknown antibody. And you'll see again that they were investigated once they were found to have this serum antibody. And the most useful investigation by far was the lumbar puncture. The CSF showed raised white cells, raised protein, NMDA receptor antibodies in the CSF, oligoclonal bands, and so forth. And that's your diagnosis. They meet Grouse criteria, definite autoimmune encephalitis. MRI, not particularly useful in these cases, EEG, somewhat. And he treated the patients. And I suppose the really sort of the light bulb moment for me, this 28-year-old woman, I get agitated and move my arms about, had an ovarian teratoma, which is a well-known association, with NMDA receptor antibodies. And the treatment, if you find it, is to remove the teratoma. So this was a lady on a PICU, thought to have drug-induced psychosis, who had an ovarian teratoma. And it was removed, and they were all given, standard immunotherapy, and the psychosis got better in those patients. Now, it's not proof of anything. They might have got better anyway. It might be an incidental findings. But again, the burden of proof for these patients, it seems to me, exactly the same as in the neurology literature, I would have thought would make people think that that's something we need to be doing and something we need to be aware of. Why are these patients in Brisbane any different to the patients in London? So I think that's the uncontroversial bit, that we all need to be vigilant. And I would say own it, that we need to be able to do these investigations ourselves, because we're the ones seeing the patients, and we need to be able to investigate people to reach a proper diagnosis. So that's the sort of, I think, the sort of uncontroversial bit. Maybe you can argue with me about that one. But the more controversial bit is that I'm come to this as a psychiatrist. And the very first patient I saw with these antibodies was on a ward in Cambridge. And actually, it was really revelatory to me because she came in a bit like the first case here. She was a young woman. She was a librarian, I remember, and she had, over a couple of weeks, became very psychotic, out of nowhere, and then was admitted to hospital where she became quite catatonic. They started her on risperidone, and she sort of dropped to the ground. She had a sort of autonomic response, and they thought, well, we won't give that again. So she wasn't treated with anything. She was tested for antibodies and found to have NMDA receptor antibodies. And I called up the neurologist on call and just said, I've got a lady with NMDA receptor antibodies. And she said, all right, I'll book her in for plasma exchange tomorrow. And I just thought, wow. She didn't want to know, any of the sort of the family history or the sort of comorbidities or anything like that. It was, she's got an antibody, she's got a serious neuropsychiatric presentation. That's enough. Of course, we'll treat her. So, and that was a really positive experience. The patient got completely better and was discharged home, didn't even come back to the psychiatric ward. The second patient that I referred was a 15-year-old gentleman with a really serious treatment-resistant mania on the adolescent unit, also in Cambridge. I don't know, Boyd will remember this one. Everyone was slightly traumatized. But so he also had NMDA receptor antibodies. He was treatment-resistant to mania. He'd had ECT. He was not eating and drinking. He was extremely disturbed and unwell. And he had these antibodies. And we tried valiantly to get him across to the neuroscience ward in Addenbrooke's, where he caused complete havoc. And he pulled down the ceiling tiles and was just really disruptive. So everybody was trying their best. But the lack of mental health nursing on the neuroscience ward, the lack of, ability to manage him in a safe environment just brought home to me, this is really problematic. He was being managed in a nursing fashion extremely well in the adolescent unit, but we couldn't give him the treatments that he needed to actually treat the underlying cause of his illness. So again, that highlighted to me, the problems with the system that we've got now. And now to come full circle 15 years later, I'm almost weekly, I hear terrible stories of where it doesn't work, basically. One particular one that comes to mind is a patient that was tested through our study who was on a section 2. I won't name the hospital actually, but they were extremely, again, a florid sort of classical presentation of a young woman who was positive for NMDA receptor antibodies and sounded a really sort of encephalopathic kind of presentation. And I said, well, you really need to refer to the on-call neurology in your local hospital, teaching hospital, large academic teaching hospital. And I heard subsequently that the doctor did call the on-call neurologist, and she started off by saying, hello, I'm the psychiatrist covering What's-It ward in this hospital. And the consultant neurologist said no and put the phone down without any kind of, which I actually think is reportable to the GMC, but that is the kind of level of divide that we have currently in the UK. Sorry to bring the tone down. Okay, so I kind of think, again, that we need to own it. And I'm also being quite thoughtful because I've been challenged quite a lot. Basically, when we started describing patients who are firmly on the psychosis side, didn't have seizures, didn't have autonomic disturbance, didn't meet the Grouse criteria for autoimmune encephalitis, people saying, those antibodies are irrelevant, Belinda, it's just going to be something else, and it doesn't really, it's not worthy of going any further or treating. They're epiphenomenal, essentially. So I was thinking, well, what level of evidence do we need to actually do things differently? What evidence do we need that these antibodies are actually causing psychosis in some patients? So I was helped out of wonderful colleagues, again, Angela Vincent and Esther Coutinho, thoughtfully put together the Koch-Witebsky postulates for a brain autoimmune disorder. These are the criteria that you would use to judge whether actually an illness was autoimmune. So the first one is that you've got to have an antibody against a cell surface receptor. So we've got that one. We know these antibodies target cell surface receptors. Secondly, you've got to show that the antibodies are there and manifest with the clinical syndrome, and you've got to be able to pick them up in the blood or the affected tissue. So more than you would see in people without the disorder. Then you've got to be able to do passive transfer studies to show that you put the antibody into an animal or a human and you would induce the illness. And that's, I'm not going to cover that today, and that's a bit of another discussion point. But I would say that almost the most important one, you've got to say that getting rid of the autoimmune response, treating it, actually improves the clinical manifestations and actually treats the clinical syndrome. So those are two things that I'm just going to focus on in the last bit of the talk. So the first thing about the prevalence and the screening studies to try and look for antibodies. We started off in the first episode service that I worked in Cambridge, and we recruited from across England, and these were patients right at the beginning of their illness. So we started off thinking, where are we going to most likely to find these antibodies? We're going to find them right at the beginning of patients' illness. So it was within 6 weeks of having presentation with psychosis and having started antipsychotics. So really hot patients, if you like. And we had a control population that was age, gender, and ethnicity matched. And this was a few years ago now, but we found overall that 8.8% of patients had one or other antibody, with 3% having NMDA receptor antibodies, a few having LGI1 and Caspr2 antibodies, and a few having GABA-A antibodies, which was really interesting. But actually, some control patients had low levels of these antibodies as well. So that overall, it was the NMDA receptor antibodies and perhaps the LGI1 antibodies that seemed to be particularly prevalent. Several studies have been done since, some finding no difference at all between patients and controls, some very large studies, and some other studies showing increased rates of antibodies. So generally, there's been a bit of confusion in the field, I think it's fair to say. So a couple of years ago, we published a mega analysis and regression to look at all of these studies, cases versus controls of psychosis patients, to say, are there increased levels of antibodies in psychosis? And overall, you say that looks a bit of a dog's dinner, Belinda, which I agree. At the top there, you've got studies showing a really high level of antibodies, up to sort of 15% of patients. And then you come down, really interesting studies of antibodies in children, the Path-Manandaval study, for instance, or postpartum studies, and then huge studies at the bottom there, like the DARM study, showing no difference between patients and controls. So what's going on? Well, we looked at the way of testing for the antibodies, and we think that basically it's the way that you test for the antibodies is really crucial. The method I told you about at the beginning, the live cell-based assay, where we grow the little cells expressing the receptor of interest, is actually quite a fiddly, time-intensive test. And there are cheaper alternatives where you fix the cells, you fix the slides, and you test the patient samples on those. But basically, in the fixing process, you fundamentally denature the receptor that you're looking at, and you lose the sensitivity of the test. So if you request an NMDA receptor antibody test through the NHS, I'm afraid you get a fixed cell-based assay test, and you may well get a false negative. If you use the live cell-based assay, which at the moment is only available through research, you're much more likely to find a positive. Also a bit more likely if you test the first episode. Okay, so everybody then says, well, serum antibodies, blah, blah, blah. You need to find out the CSF. And of course, because we don't routinely look in the CSF, that's been used as a rather circular argument of therefore saying that all the patients with serum antibodies, it's not going to be relevant. But we don't know. It's a known unknown, if you want to come back to the previous talk. But in Germany, for instance, they do quite routinely look in the CSF. And this is one such study which looked at 144 patients with psychosis, where they did lumbar punctures, and found a high rate of abnormality in the CSF. So 40% had one or other antibody. And I just want to highlight the end diagnoses 10% of those patients had an autoimmune diagnosis for their psychotic illness. That is a large proportion of patients being tested, and also would make, I think, quite a strong case for the relevance of doing CSF testing in first episode psychosis. I mean, that's a much higher rate than I think you'd find in most other neurological disorders. So that's just to highlight that F6.2 is autoimmune psychosis. Okay, so we have raised antibodies, I would say, in patients with psychosis, but it's a so what question. Do those patients with psychosis and antibodies, do they look any different? And I suppose I started off this whole journey thinking that basically we're probably missing the patients with the catatonia or autonomic disturbance, that they would be more severely unwell, that they would be treatment resistant, that they would be a bit encephalitis-like, essentially. And I want to share this, but this is unpublished data, but hopefully published soon. This is combining 3 cohorts of patients that were recruited for other reasons. So there's our PPIP 1 and 2 studies. So PPIP 2 has got broader inclusion criteria than the very narrow early onset patients in PPIP 1. ULAST was a clinical trial of long-acting injectable antipsychotics versus oral antipsychotics recruited across Europe. And Optimize was a clinical trial of patients treated with amisulpride and then either converted over to another antipsychotic and then early clozapine. But they all had blood taken and were tested for antibodies. And actually, we ran, the ULAST sample was tested initially on the fixed cell-based assay, where they found, I think, 3 patients that were positive on that assay. We ran them on the live cell-based assay in Oxford and found 14 patients with antibodies. So just again, a demonstration of the increased sensitivity of that assay. But so all these patients had PANSS scores collected, is the reason I'm telling you this, and outcome data. And you'll see the sort of demographics there. And rather to our surprise, the patients with antibodies did have slightly different psychosis scores, but they had lower PANSS scores. They had lower negative symptom scores, particularly, and lower total PANSS scores. Only a small amount, but not in the direction that we were expecting, which was, challenging and interesting. That's why I love research and love data. It's the important bit for actually advancing our understanding. And they had higher rates of remission. So what's going on? And I've been thinking about it, and I'll be grateful for your thoughts, but I think part of it is that we have a large factor of selection bias, that we screen patients that we're suspicious about, that have red flags, or that come through because people are worried about autoimmune encephalitis. And we don't do broader screening programs of everybody else. So actually, maybe these antibodies are not a marker of terrible, severe illness in all people. Maybe they're a marker of something else. Maybe they're actually a marker of responding to treatment with amisulpride. Actually, there's quite a lot of literature on how antipsychotics are immunosuppressant. Maybe we've been getting it wrong all along. So the summary of that, or maybe the antibodies are irrelevant. I suppose that's also a factor, but the fact that the patients are different from those without antibodies I just think it's more difficult to explain. But so the patients seem to be a bit different, but they're definitely not encephalitis-like in these cohorts. But the most important part, I would say, is about the immune treatments. Does removing antibodies from patients with psychosis improve the psychosis? And we've been trying to answer that question. And the way we've been trying to answer that question is through, I've run throughout the years joint clinics with lovely neuroimmunology colleagues, with Alistair Coles in Cambridge, and then with Camilla Buckley in Oxford, and now with Adam Handel and Lahiru Thandinethi in Oxford, where we discussed together what to offer people. And our approach used to be that if you have an antibody and you're resistant to symptomatic treatment and you have capacity to understand the risks posed with immune treatments, we would offer you the same immune treatments as if you had definite encephalitis. And we've been publishing our data as case series, basically. This was one that we published 4 years ago because we collected standardized PANSS scores in patients before immune therapy and then 6 weeks later after immune therapy. And you'll see, particularly in the patients with NMDA receptor antibodies, a really dramatic and pretty much total treatment of your psychotic symptoms with immune therapy. This is with the NMDA receptor antibody patients, this was with plasma exchange, and it really is a sort of Lazarus-like transformation that you see, that patients get completely better. Some patients with some voltage-gated potassium channel antibodies, but this is before the sort of delineation into the LGR1 and Caspr2 categories. So these patients didn't have LGR1 or Caspr2 antibodies, didn't really respond to immune treatments. And the patient with GABA antibodies, interestingly, didn't recover with treatment at all. And then just to sort of, I'm also perplexed as to why, again, the psychiatric community largely, or, maybe that's unfair, but overall, why we haven't said we demand that this is the way we treat patients, that everybody with a severe psychotic illness should be assessed and, if possible, offered this treatment that might actually cure them. So I controversially amalgamated all of our case series data and then plotted it on the same axis as the autoimmune encephalitis data collected by Sarosh Irani in his 2010 paper. And okay, there are a few hundred patients with encephalitis on the left there, and only 27 patients with psychosis on the right there. The y-axis is the modified Rankin scale, which is a really compressed scale of functioning the whole of life in 6 points. But if you get treated with IT, which is immunotherapy, and you have a diagnosis of autoimmune encephalitis, if you get treated in less than about 6 weeks, you have an improvement of 2.5 to 3 points on the MRS, which is a really dramatic, life-changing improvement. If you get treated with immunotherapy with psychosis, you have the same dramatic, life-changing improvement in your psychosis. And if you don't get treated with immunotherapy, you don't tend to get better. But this is open label. Everybody knows what they're getting. It's not sufficient, apparently, for the world to change. So I would say, coming back to the Koch-Witebski postulates that Angela posed for us 10 years ago, I wasn't going to be so bold as to put them all in green. I was going to leave it for you to decide. But I would say, in my mind, that we have largely met the Koch-Witebski postulates for autoimmune psychosis. But we do need evidence. And although around the world, in many countries, and I met some of you today, sort of look at me with bemusement that we don't treat patients with immune therapies, with antibodies and psychosis. In our wonderful NHS, at the moment, we can't. And actually, testing for antibodies is through research, through the live cell-based assay, is through the PPIP2 study, which is available to all of you. And our treatment, until we can persuade the world to do it differently, is through our clinical trial, where we are delivering a randomized control trial of IVIG and rituximab in patients with serum antibodies. But I really think, and maybe more rapidly than we can get on with it, I do think psychiatry needs to transform and does need to claim and reclaim the brain and claim this territory, because I don't think it's adequate the way that it's designed at the moment. So the PPIP2 criteria, just to finish on, are anyone aged 16 to 70, anyone with psychosis, and very few exclusion criteria. And the clinical trial, we have some lovely materials, and we're running it across England and Scotland, and we are getting there in recruiting, and we hopefully will have a more helpful, definitive answer for you. So thank you to everybody. It's a huge team effort. I'm standing here. I know several of you are in the audience. psychiatrists, neurologists, neuroimmunologists across Oxford and Cambridge, other universities are available, and particularly to Angela Vincent, who really is the inspiration behind all of this, and the teams across the country that are helping in this endeavour. Thank you.
So thank you very much. We're going to have questions afterwards, but I thought we would just present you with your medal lecture thing to keep your papers down.
Thank you very much.
Thanks very much.
Lovely.